Okay, good evening, everybody, and welcome to the Urowebinar from the European School of Urology. This specific webinar, which is on the identification and the management of patients with non-metastatic CRPC, is sponsored by kind grants of Bayer. However, I have to stress that Bayer was not involved in any of the content of this webinar. Next to that, next to myself, I'm Steven Joniau, I'm a urologist from Leuven. I have my colleague, chairman, Dr. Gianluca Giannarini, who is a urologist in Udine in Italy. And he's also an associate editor of European Urology Oncology, and he's in the board of the ESOU, which probably all of you know as well. So today we're gonna have a 1 hour webinar on non-metastatic CRPC. The first speaker will be Gianluca, and he will just tell you about patient identification. Who is this patient with high-risk non-metastatic CRPC? I will take over and I will go through the several trials which have been done in this area. And then at the end, Gianluca will take over again and close up with some remaining questions and also some issues regarding PSA measurements and novel imaging. Gianluca, I give the word to you. No, wait, just 1 second. There is down here in the bottom of the screen a button which says Q&A. During the session, at any moment, please ask your questions there. We will address the questions. We can do that in between the blocks or at the very end of the symposium. Gianluca, up to you.
Thank you very much, Steven, and special thanks to the European School of Urology Board for inviting me for this interesting webinar. And it's an honor for me to co-moderate and co-chair with Professor Joniau. So I will try I have no conflict of interest. I will try in the next few slides to set the scene. So as we all know, the journey that patients newly diagnosed with prostate cancer take is usually long and can be also long even if patients are diagnosed with metastatic prostate cancer. So we are now living exciting times because we have a wide armamentarium of novel life-prolonging agents that have been approved during the last decade. And so the great revolution started at the beginning in the setting of the de novo metastatic prostate cancer before any hormonal treatment or the newly diagnosed metastatic hormone-sensitive prostate cancer. And probably in this setting, the urologist in the past had a minor or a limited role in the decision making, and fortunately with the new drugs that we'll be discussing today, times have changed. And so now the new standard of care in 2020 for this metastatic prostate cancer de novo setting is based on combination. So based on several robust evidence coming from large and pivotal RCTs against placebo, we now have several or a plethora of treatments, mainly integrating new generation anti-androgens in our armamentarium. So the ADT alone is no more an indication, but we have to add to ADT or chemo, docetaxel, or abiraterone, enzalutamide, and apalutamide. And in the particular setting of patients with a limited burden of disease, the so-called oligometastatic patient, then there is also an evidence to add the treatment to the primary. For now, radiotherapy, but probably in the future also surgery. A major caveat here is that in this setting and also in all the trials that we will be discussing today, the metastatic state is determined by the use of conventional imaging. So computer tomography of the abdomen and pelvis and bone scan. Of course, we don't have any comparative head-to-head trial or study or evidence, but in some countries, the approval is still pending. But we know that based on the guidelines, these are the standard of care today. Importantly, we have to stratify the disease based on volume and site of metastasis in order to give the right treatment to the right patient. But if we move to a scenario that probably is more familiar to us as urologists, so the setting of recurring disease, then we will see that a revolution is taking place also in this setting, and due to the approval of the new generation anti-androgens, even in this setting. So this is probably also the great amount of patients that are referred to our office. And so probably this is a graph that you all know. So the patient starts with a primary treatment with a curative intent, whether surgery or radiotherapy. And then approximately in 30 to 50% of cases, we will experience a biochemical recurrence. And mostly will be treated with the ADT, which if it is prolonged and intensive, then ends up in a state that is the core of our discussion today, is called non-metastatic castration-resistant prostate cancer. So a progression of disease under continuous ADT, which after approximately 20, maximum 25 months, then ends up in the so-called metastatic castration-resistant prostate cancer, which is the lethal phenotype of the disease, and which leads inevitably to the death of the patient in approximately or less than 2 years in the best case scenario. But again, a new revolution is also taking place in the imaging. And why is it so? Because the EAU guidelines, and they are not the only guidelines, they now recommend the systematic use of next generation imaging in the form of the PSMA PET-CT. And there's, of course, a weak standard of rating because we don't have a level 1 evidence. But again, this is a strong recommendation and a strong change in the guidelines already in the last year to use the next generation imaging for every patient with a biochemical recurrence, whether after surgery or after radiotherapy, if this information could change the subsequent treatment. So we probably are leaving the conventional imaging and we are embracing the so-called functional imaging and mostly the PET-CT with the PSMA. Why PSMA? Because as of now, it is the best tracer that we have. So we used to use the choline PET, but choline PET also based or on the guidelines is recommended only in those cases where the PSMA PET is not available. So just to get to the definition, because it's also and always important to define this entity. So the non-metastatic castration prostate cancer requires three conditions. The first, it is a biochemical progression, so a PSA progression on continuous ADT, which means 3 consecutive rises in PSA measured at least 1 week apart, resulting in 50% increases over the nadir, provided that the absolute PSA level is higher than 2 nanograms per milliliter. Second condition is the castration status, which is defined by a serum testosterone level below 50 nanograms per deciliter or below 1.7 nanomole per liter. And the third condition is the lack of or absence of metastasis based on conventional imaging. That's again computer tomography and bone scan. So how can a patient get to this non-metastatic CRPC setting? Basically, through two ways. So the most common one is the patient, as I showed you before, which receive a treatment, whether surgery or radiation therapy or other form of treatment for a localized or locally advanced tumor, which then experience a relapse or a biochemical progression, so a rising PSA, then mainly or mostly receive ADT plus or minus other treatments, and then develops a status which is a castrate resistant because it's progressive despite castration appropriately given and administered, without evidence of metastasis, once again on conventional imaging. Or probably a minority of patients who are not suitable for a curative treatment or due to the age or comorbidities. And so they receive an ADT, and then they have the primary tumor in situ, and then again they experience a PSA progression with no evidence of disease on conventional imaging. So, is this form a deadly form? Which kind of prognosis have these patients? So I will start and I will show you three studies, starting from quite an old one, which is a post-hoc analysis of an aborted RCT testing zoledronic acid, a bone protecting agent, in the setting of exactly these patients. These are all comers with non-metastatic castration-resistant prostate cancer. So the first interesting data is that 1/3 of these patients at 2 years had developed bone mets, and out of 5 of them had died. So this is particularly a deadly disease, despite patients not having met on conventional imaging. And this translates in a median bone metastasis-free survival of 30 months. And the second concept is that besides PSA, it was the PSA velocity, the most informative parameter or marker to predict both time to bone metastasis and overall survival. So the PSA velocity in this study was calculated by log transform PSA values, which means that PSA velocity is the same of PSA doubling time. And I show you here the Kaplan-Meier curves, and if you see in this curve here, you see that the population with a PSA doubling time of less than 6 months, so with a rapidly growing PSA, they have the worst prognosis. So these data were later confirmed in another post-hoc analysis of the placebo arm of the denosumab RCT. So again, a trial testing the effect of a bone protective agent. And again, you will see here in this study, the population that was enrolled were patients with a PSA doubling time of less than 10 months. That means patients with the highest risk profile. So again, one important thing is that the median time to first bone met was approximately 30 months. So again, in this population, a pretty worse outcome. And in the multivariable analysis, PSA doubling time, but not PSA, was significantly associated with bone mets-free survival. And if you see here the plot, so here are on the x-axis, the PSA doubling time, higher values, meaning shorter doubling time, and in the epsilon axis here, higher values meaning increasing risk of bone or death. Then you see that the cutoff probably is here around 8 or 7 PSA doubling time. So meaning that we have a strong predictive factor for the prognosis of this patient. And then, as we will see later, it is also an informative marker for the design of RCTs in this setting. So this is an adaptation of the Kaplan-Meier curve in this study. So we superimpose the time or the bone met-free survival with the overall survival, and you see that at each time point there's a fixed magnitude, meaning that the median months from the bone metastasis to the mortality is quite short, approximately 15 months. So bottom line is again that patients with the high risk non-metastatic prostate cancer are experiencing a higher risk of death. So the last study, just confirming in a more recent publication the same data. This is a retrospective, I would say, real world data coming from 5 centers in the United States. So the authors here analyzed all the possible informative threshold of PSA density, and again the doubling time, and again the doubling time was associated with metastasis, with cancer-specific mortality and all-cause mortality. So if you see here in the plot, again, the cutoff probably discriminating the high-risk population versus the non-high-risk population is approximately 9 months. So we come again to the threshold of 10 months. And patients in the highest risk profile, so with PSA doubling time less than 3 months, have a 9-fold higher risk of metastasis and cancer-specific mortality, and a 5-fold higher risk of all-cause mortality. So bottom line again, high-risk non-metastatic CRPC is a deadly disease. What is the medical need? What or why are these patients particular? Of course, we have shown that this setting is a dangerous setting, but then patients here are by definition asymptomatic, so they don't have metastasis, so they don't have symptoms apart those from the ADT they are receiving. So what are the goals? What are the aims in this population? Of course, an aim, or the first aim, should be to delay, to extending the occurrence of metastasis, and particularly bone metastases, which are very frequent in this population, which means that we extend the time to symptomatic progression. We reduce the morbidity in terms of skeletal related events, fractures, spine surgery, and so on, which also reduces the access to healthcare resources, and so reducing the cost of this complication, and eventually and hopefully also mortality. But at the same time, we should also maintain the good quality of life that this patient by definition have. So just to introduce the talk of Professor Joniau, so we have also a revolution here in 2020 because we should treat this patient early with the new drugs, the new generation anti-androgens, due or based on a robust, again, evidence coming from 3 great pivotal RCTs, placebo control, that tested apalutamide, darolutamide, and enzalutamide in this specific population. So again, patients with high risk of experiencing metastasis, which are N0 at conventional imaging. And so this is reflected in the latest update of the guidelines. So all the guidelines, the EAU, NCCN, and ESMO are concordant in recommending the use of apalutamide, darolutamide, or enzalutamide to patients with non-metastatic CRPC with this high risk profile, to prolong time to metastasis, and as we will see also to prolong time to mortality. So this first part is over, and I don't know if there are some burning questions, and I will pass the word to Stephen.
Okay, thank you very much, Gianluca. I think that I hope you can see the slide on the screen. Not sure if you see it. Anyway, we have not so far received any questions from the audience, so please, I call to you again. Go down at the bottom of the page. There's a Q&A box, and you can ask your questions there to us. By the way, we will also ask some questions to you because this is an accredited symposium. So at the end of the symposium, you will receive some questions. We will ask you to answer these questions to get your accreditation points in the end. Now, I will talk to you about the trials that have been performed in this high-risk non-metastatic subpopulation, and you heard Gianluca tell you which patients these are. And I will just remind you, and I've been in the guideline committee for a long time, and there were a lot of discussions there what to do with non-metastatic CRPC before we had any of these drugs approved. And the guidelines, I remember very well, were saying, well, look, if you have a non-metastatic CRPC patient, please keep him on the ADT until you see metastases, because all the evidence we had was for metastatic CRPC, and we had nothing on non-metastatic CRPC. So we were keeping these patients on drugs until they develop metastases. And in fact, that's what you should remember in all of the trials that you will go through. The control arm exactly was treated like that. So they were followed up until metastatic disease. And that is exactly why this is also the endpoint of these phase 3 trials. Now, first here, these are my disclaimers. Second, why should we use AR-targeted drugs? I remember when I was a trainee, it's not that long ago, but still, we were said, okay, if hormones don't work anymore, the patient has hormone refractory disease. That's what it was called, and we didn't very well know what to do with these patients. Now, in fact, nowadays, I tell my trainees that the tumor has become addicted to testosterone, to androgens. So it's not refractory to androgens. It's the fact that the tumor has become addicted to it. And how does it go, or how does the tumor do that? Well, by producing its own androgens at a certain point. Tumors can produce their own androgens. They can overexpress the androgen receptor. And so that makes the tumor very, very sensitive to any even small amounts of androgens passing by in the bloodstream. The tumor can produce splice variants of the androgen receptor, which then, well, even without testosterone, can act as transcription factors and have, make the tumor grow. Sometimes we also see androgen receptor mutants. We know these because sometimes when we were treating patients with bicalutamide and we stopped the treatment at the PSA rise, the PSA went down again because bicalutamide was acting as an activator of the androgen receptor. So there are many reasons why the androgen receptor signaling pathway is still the key pathway in patients with non-metastatic CRPC. And now we have these drugs, and as Gianluca pointed out already, we've known enzalutamide for a long time before these trials were actually happening. And the other two, the apalutamide and darolutamide, have a very similar mode of action. They are not only inhibitors of the androgen receptor, they're also inhibiting nuclear translocation of the androgen receptor, because this receptor, we call it the nuclear receptor. When it's activated, it dimerizes with another activated androgen receptor, and both together go down to the nucleus and activate a whole lot of genes, making tumors grow. And so a third step, also the binding of the androgen receptor to the DNA is inhibited by those three molecules. Just You know, enza and apalutamide are similar in molecular structure. Darolutamide is different, and darolutamide has less penetration through the blood-brain barrier. Let's go to a case. Now, this is a case of a patient who was diagnosed long time ago with T3 prostate cancer, Gleason 7. He was, at the time of diagnosis, more than 20 years ago, he was 68 years old, had a high PSA, and after counseling, he opted for a treatment with radiation plus 3 years of ADT, exactly like the BOLA trial showed. And he benefited from this treatment because under treatment, his PSA dropped down to undetectable. After 3 years, ADT was stopped. And you can see that the PSA then in the years after very slowly started to rise, and then at a certain point faster. And when the nadir plus 2 was reached in 2008, he was considered a failure, treatment failure, and he was scanned. We scanned him with a CT scan and a bone scan, but both were negative. Ultrasound, which we were using at that time very often, much more than MRI, which we would probably use nowadays, and PET scan, we have available nowadays. Well, the ultrasound scan and clinical examination showed highly likely local recurrent cancer, no metastases. And we discussed the case in the MDT, multidisciplinary team meeting, plus with the patient, and he opted for ADT. Now you can see here the PSA values after restarting ADT, and you can see that for the first couple of years, he had a fantastic response again to the ADT. But second half of 2013, PSA started to rise, and it started to rise with a doubling time, which was calculated to be as low as 3.7 months. He was scanned again with a CT and a bone scan, and he had no mets. Now remember, before these trials, and you see them here, were started, the patient would have been followed on ADT until he would develop metastases. And you've seen what happens in those high-risk non-metastatic CRPC patients. If you follow them, well, very soon after they will develop bone mets, and not that long after, 3-4 years after, people die of the disease. Now, in order to remember the trials, you can think of PSA, Prosper, Spartan, Aramis. So that's very handy trick to remember the names of these trials. SPA or SPA can also be used, and that is the more proper order in which the trials were designed and started. But here we have them. We have the Prosper, Spartan, Aramis trials, and they all included high-risk, non-metastatic CRPC. Patients needed to have a PSA level of 2 at least, and a PSA doubling time less than 10 months. And the primary endpoint of all studies was metastasis-free survival. They all had screening for mets with a CT and a bone scan, and not with any novel imaging. Here are the baseline characteristics of those patients. As you can see, the median duration of follow-up in months was the longest in Spartan, so it is the more mature trial, and was least in Aramis, which is not as mature yet. So this trial still needs some maturation before very hard endpoints regarding overall survival can be assessed with the most clarity, because you need median survival for that. The median PSA was pretty high in those patients, not extremely high, but pretty high, around 8. And you saw by the Gianluca's talk that PSAs of 8 and above is also a risk factor for progressive disease later on. And some of these trials accepted patients with nodal disease, like Spartan and Aramis. And Aramis also accepted patients who at baseline, when they were detected with prostate cancer, had metastatic disease. So even though there were small differences between those trials, in general terms, they included very similar patients. So remember our patient here, rapid doubling time, bone scan CT negative. He was included in a trial, one of the three. It's a real life case. I'm not going to tell you which trial because frankly, I consider the results very, very similar. And so it doesn't really matter which drug you give to the patient. Well, we will discuss this a little bit later in the last part of this symposium. Remember that in those trials, the PSA was blinded for the investigators, just to allow the endpoints to be very, very clear and not like blurred or disturbed or contaminated by PSA measurements and then panicking patients or GPs and imaging for no reason for PSA rise only. This is the case after 2 years of inclusion, and we kind of saw some smaller lymph nodes appear in the para-aortic region, but they were not big enough to really say they're metastatic, so we followed up the patients. And I'm just showing you the serial CT scans that were done in this patient. And you can see, you know, throughout the years, there was some small nodes there, but that was the only thing we saw up until the moment that the GP did a PSA test. And not really allowed to do that, but you know, these things happen in clinical practice. And his PSA was 43, and the patient panicked. He came back. And actually, luckily, he was due for his next imaging very soon after, and that is what we saw. Indeed, at that time point, he had metastatic disease in the nodes in the retroperitoneum, and so he was considered a metastatic progression, and that was the primary endpoint of the trial he was in. Now let's go very briefly through the several trials that have been done. So first one here that I mentioned, out of the PSA, is the PROSPER trial. And the PROSPER trial, 1,400 patients were randomized 2-to-1 to receive enzalutamide versus placebo. And at inclusion, all of these patients were nmCRPC, and they had castrate PSA at least 2 at a doubling time of 10 or less. And there was some stratification regarding very rapid or more rapid doubling times versus less rapid doubling time, just to balance out patients in both trial arms. Primary endpoint, I said, metastasis-free survival, and then several secondary endpoints, of which overall survival, important, and also other endpoints, time to next line treatment, and for sure also quality of life endpoints. And the other thing you should know is that what these trials anticipated when they were designed was not a MFS, so metastasis-free survival difference of almost 2 years, but they were powered upon a difference of 9 months to 1 year, so much less. So when these results were first presented and then published, I mean, I think these results are really very, very positive and unanticipated because MFS, metastasis-free survival, was prolonged with 2 years, and the hazard ratio of MFS in favor of enzalutamide was 0.29, meaning that there was a 71% less development of metastases in the enzalutamide versus placebo group. Secondary endpoints published recently, very recently, a clear and significant overall survival benefit as well. And that's important because remember, patients here in the control arm were treated according to what we were using at that time, non-metastatic CRPC. You continue ADT until mets are seen, and then you treat with the classic available treatments for metastatic CRPC. So these patients were treated according to the guidelines, and the experimental group, in this case here, enzalutamide, had a better overall survival. So that is extremely important. And I think, you know, when we saw the MFS data, we could already anticipate that this would happen, but I think that there were still a lot of skeptical people out there who did not really think that overall survival would be shown. Quality of life, if that is compared between the arms, there was no difference in quality of life. Actually, there were small differences in quality of life, but in general, um, there were pretty similar quality of life scores in both arms. If there was a difference in time when patients started to fail in the placebo group, then you could see that the quality of life scores were a little bit more in favor of enzalutamide, although crossing the zero effect line or the nil difference line in many cases. So uh, similar to small benefits in favor of enzalutamide. The side effects of enzalutamide were not different from the known side effects from the trials that had been done in the past. Yes, there were side effects, and there were more side effects in the enza group versus the placebo group, but in total, the difference was not very different. And there were actually very few side effects leading to discontinuation of the drug. Um, Also important to mention is that the median treatment duration of enza was almost 3 years versus just a little bit over a year in the placebo group. Spartan trial then, that's the next trial we need to discuss. Very similar inclusion criteria. As said, patients were randomized in a very similar fashion, 2-to-1, APA versus placebo, with the same primary endpoint of metastasis-free survival. And here you can see the secondary endpoints: OS, time to metastases, symptomatic progression, and then other endpoints, among which also quality of life endpoints, which I consider very important in this population. Again, the primary endpoint was met at the first interim analysis. Very, very similar hazard ratio, very similar delay in the formation of metastases. And again, 2 years more or less difference between placebo and apalutamide. And that translated as well in a very significant overall survival benefit, which again, and I stress again, remember that the placebo group was patients who were treated according to all guidelines that were up there during the treatment or the time frame of the trials, and still there was no overall survival benefit. Regarding quality of life, again, both groups, this is total FACT-P score, like I showed you in the PROSPER trial, total FACT-P score. No difference between groups, but if you would look at least squares mean change, least squares mean change from a baseline, similar to the PROSPER trial. At a certain point in time, there was a slight benefit in favor of apalutamide. So very, very similar with if you compare this with the ENZA, with the PROSPER trial. Safety issues, there was some safety issues. There were side effects, obviously, but again, between the placebo and apalutamide group, there was not a huge difference in the percentages of any adverse event, and also in percentages of grade 3 or 4 adverse events. In this study here, which is a recent one, also the patients who switched from the placebo group to the crossed over to the apalutamide group are also looked at, and here again, side effects were not very different if you compare with the apalutamide group. One of the side effects that were seen, or that we see also in clinical practice, is some rash that can appear. It's a skin rash. Sometimes you need to treat it with ointments, sometimes even with corticoids, local corticoids. But if you stop the drug for a couple of weeks, it goes away. If you restart the drug, then it never comes back. So the skin rash can be dealt with. Besides that, some hypertension, some higher risk of falls, but not very, very different between placebo and treatment groups. And again, we will come back to that in the third part of the talk. And lastly, the third of the three musketeers, Aramis, and I don't know if you know this movie here, Slumdog Millionaire. That was the $1 million question. who was the third musketeer? And okay, obviously he answered correctly and won the millions. Let's see if whether the Aramis trial also is the winner of the pack. Similar patient inclusion criteria, seeing the slight difference that N plus patients were also allowed here in this trial. But apart from that, again, a 2-to-1 randomization daro versus placebo with the same primary endpoint and very similar secondary endpoints. So very comparable to the two other trials. This again is the primary endpoint of metastasis-free survival. Again, very, very significant difference. Hazard ratio a little bit higher, but still comparable to the two other trials with ENZA and APA. And the overall survival endpoint here, I have to stress that the trial is not completely mature because we need some longer follow-up to know the median survival in both groups. And we don't know that yet, but still we have a very nice and very significant hazard ratio pointing to a very similar benefit in favor of darolutamide regarding the overall survival endpoint. Secondary endpoints, and here, interestingly, it was looked at time to pain progression, and you can see that pretty soon, and as soon as a couple of months from the start of the trial, and certainly after a year, the curves nicely split in favor of darolutamide versus placebo. And then there was a detailed analysis. You can find it in the paper supplements in New England Journal. Again, in all these subdomains of quality of life and pain interference, there was very similar scores between daro and the placebo group, with differences, if there were differences, usually in favor, slightly in favor of darolutamide versus placebo. Side effects, well, a lot of discussion has been going on regarding side effects and the fact that there were pretty, well, less side effects if you would compare the Aramis trial with the other trials. In fact, there was no one of the side effects which were seen in the other studies, falls, seizure. Well, seizure, I mentioned that here because seizures were not seen in the other trials, but seizures is marked here because patients with a history of seizure could be included in the daro trial, in the Aramis trial. But no mental impairment or disorders, probably due to the fact that the penetration through the blood-brain barrier is much less. Also, hypertension was not really seen if you compare daro versus the placebo arm. Again, well, in order to really conclude regarding side effects, I think we need to look at the data a little bit differently, and we will come back to that in a minute after finalizing this here. So that is, remember what happened to our patients, or where he ended, and when the patient was was unblinded, and then he had a choice: continue with the study drug or switch to something else. And he was receiving the study drug, not the placebo. It was not in the placebo group, so it was either continuing or rather go for possibly chemotherapy, because we know that one androgen receptor agent after the other is usually not the best idea. But in the meantime, he's 88 years old, and he refused chemotherapy. He's also not the best candidate for chemotherapy. We discussed, and then we said, okay, what we could do is give him DEXA in a low dose, 0.5, and just follow him up. And we saw that the nodes were growing, but the PSA actually stabilized. And that is since his unblinding up until September last year. I lost track of the guy. Maybe he died in the meantime, I don't know. But at least he had another more than a year of on the drug with adding dexamethasone. I'm going to skip the summary because we're going to come back to you with the summary after Gianluca's talk. So Gianluca, I return back to you, and yeah, let me see. Stop share. Okay, that's it.
Okay.
All right, Gianluca.
Thanks, Stephen. Wonderful presentation of the trial. So just to, I mean, anticipate a question. So which of the three drugs is the best one? So very difficult question and difficult answer. So I think we discussed with Stephen whether we should show you these slides because as you probably may imagine, it is not easy to pull all the data from three large RCTs, even though the inclusion criteria are pretty similar, because of course there should be differences in patients enrolled in this trial, although again the profile, the risk profile, and the performance status and all the characteristics as should be in an RCTs are pretty similar. But so we decided with, of course, with a great caveat. So here I show you three, because there are more than this, but the three latest publications, which are systematic review and meta-analysis with a particular methodology called network meta-analysis, when you have to compare three different drugs, in this case, that do not have head-to-head comparative studies. So this may be viewed as a very high level of evidence, but we would like just from now to urge all of you to just not over-interpret these findings that we will show you in a second. So there are no head-to-head comparative studies. Probably it will be difficult to design such studies for many reasons. But then these are the results. So the three network meta-analysis have mostly concordant results. And so if we look at the metastasis-free survival, which was the primary endpoint in all three studies, then there's a slight prevalence or preference for APA and ENZA over DARO, and this is based for mainly based on the slightly higher hazard ratio for the MFS in the ARAMIS trial. Number two, for overall survival, APA and DARO probably slightly preferred over ENZA based on the secondary analysis of this secondary endpoint. What about toxicity? Again, DARO probably preferred slightly over APA and ENZA, but this is probably the most informative slide when we talk of side effects comparing the three trials. So if you just look at the placebo arm, then you will realize that the placebo arm that in theory should all comprise or include similar patients have in fact different profiles of side effects and toxicity, probably underlying baseline different characteristics. So if we just adjust the placebo or the treatment arm with the placebo arm, then we just realize that probably there are not that many differences, or the magnitude of the difference of the drug versus placebo in the T trial probably is not that high. So, and this you can see here nicely with the numbers in red. So apart from the rash, which is probably typical for that trial, but if you see the fatigue, hypertension, or the CNS events, seizures or falls, on mental impairment. At the end, there are no striking differences between the three drugs. So this is a warning again, so you have to exert extreme caution in interpreting such a network meta-analysis, because again, there are no head-to-head well-designed comparative trials, but we can only do indirect comparisons. Importantly, these meta-analyses were published before two of the three trials had published the full results of the overall survival. Of course, there is not a standardized monitoring schedule for this trial, because in one of those trials, the monitoring of the patients and therefore of the side events was more intensive compared to the other two. And so this could also play a difference. And of course, at the end, the choice is multifactorial. So it is based in the real life, so outside RCTs, on the characteristic that we all know. So performance status, comorbidity profile, preference, and last but not least, the local approval of these drugs, country by country. But then we will like to end this webinar with the hot topic for debate, which is the role of the functional imaging. So what would happen if we would use or apply the next generation imaging to these patients? So this is really a clever study, because the authors picked up, it is a retrospective studies, okay, with all the inherent biases, but still is very informative. So 200 men with the same characteristics of the patients in the RCTs. So high risk, non-metastatic CRPC by conventional imaging, defined as a PSA doubling time less of 10 months and or a Gleason score 8 or higher, even though many patients with this Gleason score had a PSA doubling time less than 10 months. So pretty similar. And what happened? So the old patient received a PSMA PET-CT, and strikingly, only 4 out of 200 men, so only 2% of these scans were negative. Importantly, more than half of the patients had a distant metastasis, which we all know have a worse prognosis, and 44 of patients have pelvic lesions. So the second part of the study is that the authors run a multivariable analysis to just find predictors of positive imaging, so M1. And then they found 4 factors: PSA at the time of the scan, pathological N1 in those patients who had surgery, radiation therapy as primary treatment, and salvage radiotherapy as a salvage treatment. And so they applied, or they stratified the patients of one of these trials, the Spartan trial, by all these factors. And then they found that in all patient subgroups defined by these 4 factors, all these patients ultimately benefit from apalutamide. So the authors conclude that an improved identification of metastatic disease does not justify abandoning the standard of care treatment in patients who have a non-metastatic CRPC based on conventional imaging. So this is clearly opens the door to many questions and many possible paradigm shift. So one, for example, but then we will, of course, have time to discuss based also on the questions that are coming right now. So we don't know if we detect early metastasis in this population, if this is really beneficial. So one may argue that, okay, these patients are metastatic, so we have to treat them as a metastatic CRPC. But as we know now, mainly the two armamentarium or the two set of treatment that we have for non-metastatic and CRPC and metastatic CRPC are probably the same. So it is only a matter of a stage reclassification, probably with no improvement in overall survival. So based, number two, for example, is based on this study, 1/3 of these patients had an oligometastatic disease or a phenotype. That means 3 or less positive PSMA PET lesions. So, as you know, there's a strong interest, and there are lots of trials going on the metastasis-directed therapy based on the next generation imaging. But we don't know if this kind of therapy is better or worse than an early systemic treatment. And again, if we start giving systemic treatment early in this setting, so before patients have visible metastasis, then we completely change the following step. So we completely change and possibly the biology of the disease that we have to treat later on when this patient inevitably will develop a metastatic CRPC. So there are really many questions based on the functional imaging, which is right now probably the standard of care, but is not the standard of care in this particular population. Another point of debate is how often should we follow the patient. And I show you two documents coming from two consensus of experts. One was published last year, so probably at the beginning of the release of the data of the 3 trials that we have presented. And so in patients with mCRPC, the next generation imaging, which are again mainly based PET-CT, should be reserved only for patients with a short doubling time. So the patients which are at the highest likelihood of develop metastasis, when, of course, the therapies for the metastasis would be appropriate. So this is, of course, a pretty conservative recommendation based on practically no level of evidence except for retrospective studies. The same conclusion is here in this another further publication, which include really a truly multidisciplinary panel with radiologists, nuclear medicine physicians, and onco-urologists. And again, the recommendation is that the next generation imaging, and here the expert adds also the whole body MRI, but the whole body MRI probably has a lower penetration in the world, can be offered only if a change in the clinical care is contemplated, which is again rather critical or conservative statement. But then they advocate the use, of course, of this functional imaging in the context of clinical trials. Even in the metastatic CRPC, so in the next phase of the disease, which probably is the same or the earlier, if we apply next generation imaging, there are practically no strong recommendation. And again, the integration or inclusion of this imaging in the clinical trial is recommended as the best way to gain knowledge in this field. So what about the PSA? Could it be useful to trigger imaging? These are very recent data. This is a post-hoc analysis of the Prosper trial. And the authors just explore the hypothesis that probably the definition, which many of you probably know, which is integrating in the trial, in the Prosper trial. So the PSA progression defined based on the definition proposed by the Prostate Cancer Working Group 2 is valid to predict the appearance of metastasis on imaging. And then they show, finding number one, that the risk of metastasis or death was significantly increased, as you see here in the Kaplan-Meier curve, in those patients who had PSA progression, based on this definition, versus those without progression, but only in the treatment arm. But importantly, the median maximum increase from nadir at the time of the metastasis was below the threshold required by the definition. So the threshold is 2 nanograms per milliliter, and the median maximum increase was 1.4, meaning that half of the people had less than 1.4. So the authors conclude that the radiographic progression often occurred without PSA progression, suggesting that any increase in PSA may probably warrant closer monitoring or warrant a trigger in imaging. But what kind of imaging and how often, we don't know. So just to summarize, the open questions due to introduction of the new standard of care of imaging are if early systemic treatment is really beneficial to this patient. What is the role of the metastasis-directed treatment based on the findings of the new generation imaging? Should we use this alone? Should we combine with systemic treatment? We don't know. How to best follow this patient with functional imaging? We know that in many cases, progression occurs also without a PSA increase, but we also know that PSA in some patients can have a validity just to trigger further monitoring. And importantly, can functional imaging be used to monitor treatment response? As of now, we don't have any solid data to answer these questions. So we are going to the end, and I just show you which could be the changing landscape of recurrent prostate cancer based on the integration of early imaging in the cascade of events. So we start again with a patient with a biochemical recurrence after primary treatment. And so at this point, based on the latest guidelines, we should apply the PSMA PET-CT. And so we can have two, of course, conditions. So if the PET PSMA is positive, then we could go for a metastasis-directed treatment, of course, knowing that this type of treatment is purely experimental as of now. And we also don't know if we should combine a metastasis-directed treatment with a systemic one. If the imaging is negative, then we can have a wide choice depending of other factors, mostly the doubling time and the Gleason grade or the ISUP grade of the primary tumor. So we can go from observation if the progression of the PSA is very long, to salvage local treatment or to systemic treatment, mainly, again, at this time, ADT. If the patient does not undergo a functional imaging, then we can have the same with the conventional or negative conventional imaging or no imaging at all. Patients who are prescribed an ADT plus or minus salvage local treatment, and so we end up in this condition, again, the non-metastatic CRPC, where we know that based on the data we have presented, if the patient has a higher risk profile, which is defined again with a rapid, very rapid doubling time, then we can anticipate this treatment and treat them early to improve metastasis, pre-survival and overall survival. And then we can go to the metastatic CRPC, which is the chapter for another webinar. So we would like to conclude with these take-home messages. And so we know that the early use of systemic treatment has really changed the approach to advanced prostate cancer. So the landscape has completely changed. And the early use of novel anti-androgens and docetaxel has improved overall survival in metastatic prostate cancer hormone sensitive. Plus, we know from these 3 trials that the early use of apalutamide, darolutamide, and enzalutamide has improved metastasis-free survival and overall survival, but in the high-risk population. So these agents can be used quite comfortably. They have known and manageable side effects, and some of them we know from some years now in other settings, and importantly, are associated with a stable and maintained quality of life. And again, many open questions remain as to the role of the functional imaging and possible image-guided metastasis-directed therapies in this setting.
Thank you very much. So, yeah, thank you, Gianluca. I've been looking at the Q&A box, and I saw quite a lot of questions coming regarding the new generation imaging, and that's the whole point, isn't it? Yeah. Once PSMA is introduced in a country, and yeah, Italy, Belgium, we know how it goes. We've had this available for years. People start to use it, and you feel it changes practice. But I think we need to make a clear point regarding the use of new generation imaging and non-metastatic CRPC. In my mind, there is no place. And you said it. So we should not use new generation imaging PSMA PET-CT. It's very interesting because highly likely when patients only have a local recurrent tumor, they may still be eligible for radiation, but we don't know. We have no data on that. What we do have, and I want to stress it again, is that if you compare with a placebo group, and these studies were placebo-controlled, is that you can have a vast delay in metastasis-free survival, a prolongation, I mean, in MFS. Plus, you also have benefits in overall survival. I think so far that the place where new generation imaging is at its best is at the time of biochemical recurrence, but in hormone naive or hormone sensitive patients. And still, there is a lot of work to do there. And then one question maybe to you, also from the audience, is that the question is, if we take into account the adverse events, what is the real difficulty of managing these treatments? I just want to hear your views on that.
I think that we are really quite comfortable as urologists because I think in this in the last decade or last couple of years, then the treatment and the possibility to prescribe these drugs has completely changed. So probably we were reluctant as urologists to approach this scenario because of course we are not keen with managing chemo, for example, or but I have to admit that now that the situation has changed, so we can safely prescribe and follow the patients ourselves. So we know the side effects profile, and we also know how to manage. So they're really quite an easy task for us.
Yeah, I would agree. If you really would say, okay, which patients are not eligible for any of these drugs, I don't know. I would say that patients with really cardiovascular, extensive disease, and hypertension, which is not well controlled, probably ENZA or APA would be less eligible compared to darolutamide. Same for patients with a history of stroke or seizures. I would rather go for darolutamide rather than any of the other two. Also, patients who are already a little bit confused and old and maybe a bit well, dement, early demential, I would rather maybe go for darolutamide. But at the other hand, um, as you said, and you pointed out very well in your table there is not a great difference in side effect profiles between these drugs. So there is not really, you cannot almost not really make a mistake in prescribing one over the other. We have to accept that they are very, very similar in their effects on MFS and overall survival, and that the side effect profiles are very comparable, even though in patients with a lot of comorbidities, that's probably darolutamide is the easier and the most obvious drug, but that is a smaller selection of patients.
Yeah, yeah, I agree. Just even to get back to the question of imaging, I think we
Yeah.
got many. So, do you think that this space, I mean, the non-metastatic CRPC, is likely to increase or to decrease? So, to me, of course, if you apply imaging extensively, then probably this space will decrease. But then we
Yeah.
also know that we are anticipating lines of treatment earlier in the disease. So now there's a great, of course, we are probably as urologists or radiation therapists treating higher risk diseases. And in this field, there is lot of combination, neo, perioperative or peri-treatment adjuvant therapy,
Yeah.
also integrating the new anti-androgen. So we are probably intensifying our treatment early, and so
Yeah.
we will probably have more and more of these cases in a couple of years. So your take on this?
Yeah. I, I, I feel a little bit, I have a little bit of a different feeling. You're quite right that we are not anymore treating intensively low risk and the intermediate risk. There's a part of them that we can probably follow up and so forth. So the patients who we treat with surgery, radiation, obviously a lot of them will need hormones at a certain point in time. So I fully agree with that. But the problem is that that once you get PSMA PET-CT available in your country, what you do is that if they are treated locally and they recur, then the you will be tempted to wait a little bit until you see something on a PET scan because treating small amounts of metastasis, oligometastatic disease with targeted metastasis directed treatment is very appealing. And there's some data showing in phase 2 trials showing that, yes, there is some benefit there. The problem is this has never been formally compared with starting ADT at the same time. So we don't know really what is the best of the two. Or maybe we should combine both. And the other question is that, okay, why? Because one of the questions was, yes, but so is this an early versus late trial? In fact, if you interpret, in a sense, yes, because if you scan at the time when you include the patients, you show that half of the patients already have mets on new generation imaging. So you treat them earlier, but you can't see them yet on a classical bone scan CT, but you already treat them with a very active drug, and they seem to have overall survival benefit. I think this is the best take home. Next was, very importantly, was that apalutamide was only licensed for non-metastatic CRPC. Now it's licensed for more than that. Darolutamide is only licensed for non-metastatic CRPC. So maybe these are drugs which you cannot prescribe later on, and maybe there is a benefit from prescribing any of those, and then you still have all the other drugs for later. But I think this PFS2 question, which is still not resolved in my opinion. So I'm not sure if after darolutamide, enza abiraterone is still going to be effective, because we know there's a lot of cross resistance. So I would still say don't do PSMA PET-CT scans, not yet for primary staging, before you do local treatment. We have this Hoffman trial in New England Journal showing that it's highly likely better, but it's only one trial, and we don't really know whether it changes the outcome of the patient. Second, probably if you use PSMA PET-CT, use it in the recurrent patients, and don't yet use any of this new generation imaging in the non-metastatic CRPC setting, because you're gonna be seeing a lot of stuff, and you're not gonna know what to do with it, because there's no data on any of the treatments you would do. There's no good data on that.
Yeah, I agree. I think one potential pitfall is probably we have to warn also our colleagues from the nuclear medicine, because okay, if the notion and the concept if is that the non-metastatic state does not exist, then probably they are more prone to overcall also small or indeterminate lesions. So probably the risk would be that almost all or the majority of the scans turn to be positive also in patients who do not have the eye profile. So this is probably
there's another thing. Yeah, you're right. I agree. And the other thing is that, and the nuclear medicine, colleagues, they acknowledge this, that there is also a high false positive rate. So always be aware of the high false positive rate of these PET scans. Gianluca, I'm afraid we have to stop because we're already running over time, and I think that some of the attendees are waiting until they get the questions at the end so that they can, or well, they will be sent. They will be sent, I believe. I'm not sure, but there will be questions, like 6 questions, to just double check whether you've paid attention to what we said. I want to thank you, Gianluca, again. I want to thank everybody, all the attendees. We had a very good audience tonight, and I'm very happy with that. I think I speak for the both of us that we're also very happy with the Q&As, and we've answered some of these questions in typing. So if you go to Q&A, you will see the answers to many of the questions that we provided. I want to also, just repeat that this symposium was possible through a kind grant from Bayer. They were not involved in any of the content, but obviously, in order to be able to do stuff like this, we need sponsors, and we're very, very grateful for to Bayer for providing this grant to us. Gianluca, I leave it to you to close the session, and then we'll,
I echo your words, and so it was also for me a pleasure to spend 1.5 hours with you, Stephen. And so thanks again to the European School of Urology for this great opportunity, and to Bayer to discuss a very hot topic. And I think we deliver some content, and we are happy to receive your question, even if in the coming days. So thank you again.
Thank you, everybody, and bye.